What's going on, everybody? Welcome to another episode of the Core Consult RX podcast. Cole, what's going on, buddy?
Not too much. We're recording earlier than normal today.
I know.
So the sun is out.
Sun is out. Well, it's been out because it's been daylight savings.
AJ's not here.
Oh, AJ's not? Everyone look at AJ on the video. Look, he's just absent. We need to have...
We still have his camera rolling, though.
Of course. I did it just for this.
just so you can show
everybody he's not there. So yeah, I will be your camera guy this evening, and so I'm probably going to do a horrible job.
Which means that I'm going to have a lot of talking to do while you're on.
Yeah, because I'll just be distracted the entire time. But this is honestly, I think that's actually fitting because this is your fault that we're talking about this topic.
It was my idea.
Yeah.
Well, we didn't have anything else.
We didn't, and so instead of saying, "Hey, let's do an easy patient case" or something like that, like I would have done because I'm a little bit lazier, Cole said, "Hey, let's cover that new ALS drug that neither one of us know anything about at this moment."
Yep.
I can't let him outdo me, so I had to agree.
I mean,
so here we are.
Well,
two guys trying their best.
I know, but it's not like either of us know anything about ALS. You know,
right.
I actually first heard
That's why I didn't think we should do the topic, but you know,
I was familiar with, I guess, the drug a little bit because drug companies do a weird thing where if a drug is in the pipeline and maybe it's nearing approval, the drug reps can't call and tell you about the drug. They're not allowed to because it's not an FDA approved drug.
It has to be approved.
But they want to get feelers out there and establish contacts. So when the drug is approved, they know exactly who to go to push the drug. And so you get these weird phone calls. So I believe this is from Amyotrophic Pharmaceuticals. I think this is the one that I was getting calls about. You get these weird phone calls from these drug reps who are like, "Hey, just calling about, not about a drug, just about ALS, but you know, there might be a new drug approved for ALS, just so you know, and we want to know like who the people to contact are and blah, 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 blah." So they like call and kind of bug you to give them contacts, and they just try to like surf just like, "Oh yeah, so-and-so told me to contact this person, so-and-so told me to contact," and they do a lot of name dropping just to get as much information as they can, so when the drug is approved, they can push it.
What's there to be gained by that, though?
I guess it just makes it easier for them to push it, you know, for them to have the people, for if it's a relevant clinic, for them to have the contact people who are going to be prescribing it, support staff.
So they're just trying to like make a friend before they have to go.
I think so, because Anna is in memory disorders.
Yeah.
And for the year leading up to that Alzheimer's drug coming out, the name's escaping me.
Yeah, I know what you're talking about. That starts with an A, monoclonal antibody.
Yeah, it'll come to me in a second.
Yeah.
She had like somebody bugging her like constantly about it and trying to like get her to set up these meetings and all this kind of stuff. But like couldn't actually talk about the drug. It was just like...
Well, why would you want to?
I know. No,
it's better to just set up the meeting and just hope for the best because...
So that was where I first heard about this, but then I hadn't looked into it much because I don't work closely with ALS. But after it was
somebody in your apartment that does, right?
So we do have someone in the department who works with ALS.
Do they only do ALS? Is it?
They do MS and ALS.
Okay, cool.
Yeah, they do both of those.
Because I can't imagine ALS is that prevalent, even in a big, hospital like you.
No, yeah. I mean, we have like an ALS clinic, so they come from all over to see us. But still, yes.
Does someone like specialize in that specifically?
Yes. So I think there's there's two MDs, a nurse practitioner, maybe somebody else who like actually does ALS.
Okay,
yes.
Gotcha.
I think they probably do other things.
Yeah, but they probably have I
don't know what their specialty is.
I would think they have extensive training, and it'd be like a pulmonologist has extensive training in like pulmonary hypertension.
Right. They're just called a neurologist, as far as I know.
Yeah, I'm sure.
But they
probably just have
a lot of training with they are the people who see the ALS patients. So yeah, I mean, there's maybe relatively speaking, there's a fair amount like versus like other places that you'd go. But compared to other disease states, no, it's a small number. Very sad small number of people who it's awful disease.
Yeah, very, very much so. Yeah. So speaking of ALS, tell us what is it?
Yeah, so that's what we're talking about. So ALS stands for Amyotrophic Lateral Sclerosis. Many of us might be familiar with it because of the ice bucket challenge that went all over the place in, what was that, 2018?
Man, before that? I was trying to think of that when you brought that up. I really don't know when that was.
It was a long time ago.
Probably 17, 18.
Yeah, maybe a little bit before COVID.
Yeah.
So you're probably familiar with it. That's what this is. And so we're going to just briefly tell you about what it is and a couple of the current treatments, but we want to focus on this new drug because where I kind of sparked my interest was I heard that it was a bit controversial that it was approved, and almost in the same vein as that aducanumab.
Aducanumab, look at you.
Told you it would come to me.
That's impressive.
Kind of in that same vein, and I looked into it. It's not nearly as controversial as that, but there was a little bit just related to whether it's that efficacious or not. So we'll talk about it.
I mean, from what I was reading, the execs kind of put their, I think it was one of the CEO, the co-CEO or something. He kind of put his challenge out there based on the new study that's going to be coming out. He's kind of like, yeah, if it doesn't work out, then we'll take it back. I was like, whoa.
Well, the new one is looking more promising.
Yeah.
Than the one we're going to talk about here.
So I thought that was kind of cool. Usually they're like trying to make excuses and like, oh. There was a difference with Prevnar 13, well, whatever. And but now this guy's like, I'll take it off the market if it's not successful. So we'll talk about that.
I hadn't heard about that. So he put some skin in the game.
Yeah. I mean, again, that's what I'm reading on Medscape News and stuff like that. Right. So I don't know if that's actually binding, but
yeah, that's very interesting. And
he gave him a firm handshake, so it had to be legitimate.
It had to be. So yeah, let's talk about ALS for a second. So I said it stands for Amyotrophic Lateral Sclerosis. What does that mean? It's a degenerative disease of the motor neuron system. Sounds kind of familiar to MS, but it is different. And this is the most common degenerative disease of the motor neuron system. It's incurable, it's fatal, and the median survival is about 3 years. I've heard like 2 to 5, but the median survival is 3 years. Treatment can extend life. It's I don't know, it's not that significant, like a number of months usually, but it can help with meaningful quality of life in patients. So you'll see that when we talk about this study, a lot of it is related to quality of life measures, and they didn't necessarily see the extended life that even we have with a couple of the other treatments, and that's what they're looking for in that
the extended life,
the trial that Mike referenced, that CEO or whatever exec guy.
It was like, that one's not cool, but the next one's gonna be.
Right.
I bet my drug on it. So signs and symptoms. So patients, and this is a vast majority of patients, up to 80%, will sort of have their symptom involvement begin with the limbs. So they'll have, the lower limbs being affected, or they're starting to trip or stumble. They might have this sort of awkwardness when running that wasn't there before. Foot drop. So patients may even report like a slapping gait. And then from an upper limb standpoint, usually it's the reduced finger dexterity, cramping, stiffness, and then like wrist drop interfering with work performance. And then bulbar onset can start to happen, and that's where you get like the slurred speech, the hoarseness, decreased speech volume, aspiration and choking in general become a real concern at this point. And then also some of the emotional and other cognitive difficulties can start to arise the longer the patient has the disorder, where they, obviously depression is something they're dealing with, maladaptive social behavior, even like pseudobulbar affect, where it's like involuntary laughing or crying, is another thing that can occur over time.
Who does the commercial for the pseudobulbar affect? The new Dexter or whatever?
Danny Glover?
Danny Glover?
Yeah. Because he would just laugh and then he'd start crying. Like, what is this guy doing?
Yeah.
He's like, I'm an actor. But some people can't do that.
Right. That's
like, it's a weird way
that commercial a few times.
Yeah, it's like a weird way to sell that.
It was a very interesting sell. So that's what people would see neurologically,
or symptom-wise.
Symptom-wise, as time goes on, they're going to deteriorate. Features of more advanced disease would be muscle atrophy that becomes more apparent, spasticity that might compromise their ability to walk or their manual dexterity, a lot of muscle cramps, rarely painful joint contractures may result from immobility. And then there's also, so that's the motor, there's also progression of the bulbar disease. So voice changes, hypernasality, and development of a strangled vocal quality. So their voice is going to sound a lot different. And eventually their speech will probably be lost eventually. Swallowing difficulties. A lot of times they have to have a feeding tube or a peg tube, usually starting with liquids, and then excessive drooling. So there's a number of things that will happen over time.
Do you want to talk about any of the diagnostics stuff?
Yeah, I'm not too up on all the diagnostics, but it's what I will say is that a lot of the, especially early signs, can be kind of non-specific when it comes to a neurologic standpoint. So it's not always diagnosed like your first visit, right? There's going to be a number of things on the differential that are causing some of these non-specific ataxia-type symptoms and motor issues and even emotional issues. So they kind of break it down based on symptoms and how sure they are that it is ALS. I won't get into all of it, but basically they assign them different stratifications like clinically definite, clinically probable, laboratory supported, clinically possible, and then clinically suspected. And that's just all related to their symptom types and where their symptoms are happening.
Yeah. And to that, same idea, the patients oftentimes will be kind of categorized as having like probable ALS or possible ALS until they can get more information and the disease maybe progresses so that they have more data to work with before they can move to like definite ALS. There's also some other like related forms of ALS. So things like progressive muscular atrophy, things like progressive bulbar palsy, ALS plus syndrome. There's a few others that all have like their specific differential or criteria to meet in order to reach that diagnosis, but a very complex situation. They'll do electrodiagnostic studies in a lot of cases, electromyographies, nerve conduction studies, all kinds of stuff. So that's why the neurologists get paid the big bucks.
Right. And as far as managing their condition, it's not just one doctor that they're going to have that's going to manage everything. They're going to see a number of specialties, speech therapy, dietitians, a number of things. So they're going to have a lot of appointments. So with their management, there are ALS-specific medications that we can use, 2 previously and then 1 new one. Riluzole, branded as Rilutech. It comes as a tablet and a suspension. And then edaravone, which is Radicava. And then the new one, which is Relyvrio. And so we'll get into those in a second. But along with offering the ALS-specific drugs, there's a number of other things. We mentioned parenteral nutrition if they need it, non-invasive ventilation, and then eventually maybe invasive ventilatory support requiring tracheostomy, depending on the case. Apparently people will try to use like creatine and stuff like that to help with the muscle wasting, but that's not recommended. But there's other things to treat the emotional symptoms like benzos for anxiety, SSRIs for depression, NSAIDs and other pain medications for various pain issues they may have. Anticholinergics and sympathomimetics for the excessive drooling, mucolytics for thickened secretion, muscle relaxants for spasticity. So a whole host of issues that are going to come as time goes on that we have supportive medications that can kind of, again, help with their quality of life. And when we talk about the Relyvrio study, we'll talk about one of the main kind of quality of life questionnaire that they use to establish efficacy, and you'll kind of see what they're looking at as far as improved quality of life,
and whether that's clinically relevant.
Whether it's clinically relevant, yeah, that sort of thing.
The other thing that, just speaking of drooling, since we're talking about other medications to be used, in 2009, the American Academy of Neurology published this, basically an evidence-based practice parameter update, and they were talking about using botulism toxin B for the refractory or treatment of refractory drooling after standard medication. I'm assuming like atropine and things like that. But they also said that low dose radiation therapy to the salivary glands can also be considered as well. So it's pretty intense. Yeah. And then since we mentioned pseudobulbar affect, with about 20 to 50% of patients will develop this that have ALS, and so that product that we were talking about the drug commercial for is a combination of dextromethorphan and quinidine. And I think that dextromethorphan, if I'm not mistaken, is used more so for basically it works as almost like an inhibitor for the metabolism. Is that right?
I don't know enough about it, but that sounds right.
Okay, because I think there's another dextromethorphan-based psych med that just got approved too. So it's on my to-do list of things to look up, but kind of interesting. Yeah, but that's definitely not an active ingredient I would expect to see
No.
getting new FDA approvals.
Isn't there some weird abuse that can happen with dextromethorphan?
Yeah, they call it robo tripping and stuff like that. You basically just have to. It's a lot of times younger kids. That's why there's an age limit now. Like we have to. I think you have to be at least 16, maybe 18, to buy any sort of like dextromethorphan containing product. Because kids
you do, don't you?
Yeah, because kids were drinking a bunch of it and then they basically inducing
like the
delirium.
Delsum stuff.
Yeah, they were like inducing delirium.
What the world are people doing?
I don't know.
Jeez.
I don't know.
Making it all.
I blame the school system.
I blame public education.
I blame public education. Oh, that's a joke.
Yeah.
Okay, cool. So I guess, do you want to do a little bit of background on the other two drugs you mentioned?
So we'll tell you about the other two drugs, then we'll kind of hit the new one. So riluzole is sort of the mainstay, kind of the original ALS drug. Like I said, it's branded as Rilotech and one other brand name for the suspension. But it's generic now. For all patients living with ALS, it's generally recommended to treat with riluzole. There's 3 separate mechanisms thought to reduce the glutamate-induced excitotoxicity by inhibiting glutamic acid release, non-competitive block of NMDA, not NDMA, different. This is N-methyl D-aspartate receptor-mediated responses, and direct action on voltage-dependent sodium channels. Which is interesting because that's a similar mechanism to some like anti-epileptics and things.
That is kind of weird. I guess because they're blocking glutamate.
Yeah. Yes, so that makes sense. Though, as far as how it helps with ALS patients, it's unclear because none of that is like directly related. So they do recommend it. Most likely, patients are going to see some functional improvement in their quality of life, and then they may see some survival benefit. So in one prospective double-blind study, about 155 patients, survival at 12 months was significantly higher for riluzole group, 100 milligrams a day compared with controls. And that was 74 versus 58%. So basically at 12 months during the study, 74 patients in the treatment group were alive, 58% in the control group were alive. For the subset of patients with bulbar onset ALS, an even greater advantage. So interestingly, they saw there was almost a 20%. So for bulbar onset ALS, the riluzole group, 73% survival at 12 months, control group, 35% survival. So I find that very interesting. But generally what I hear said is a few months. A few months is kind of what you could expect from the survival benefit.
And the edaravone is another product that is basically suggested for all patients with ALS. But it basically is a free radical scavenger, so it's thought to kind of reduce oxidative stress. And, that's oxidative stress has been thought to play a role in development or worsening of ALS. So make the mechanism, I guess, make sense. But, the evidence is the highest, or at least shows the highest benefit in patients with early ALS. Technically speaking, you can't, there's no reason to not use it in other older or more further along patients or more progressive disease, I should say. And so it's also recommended to give this medication to all patients with ALS. It was approved originally as a IV formulation in 2015, and then in 2022 it was approved as a oral formulation, and specifically in Japan and Korea, and then the United States got FDA approval back in 2017 initially. So it's been around for a little bit as well. The studies that were done looking at this versus placebo, again, show kind of an overall benefit in function and whatnot, but a post hoc analysis showed a greater treatment effect in the subgroup of subjects with basically definitive or at least probable ALS, based on a ALS FRSR score.
Yes.
So we can talk about that in a second if you want.
Yep.
But so those meds have been around for a while, and that's kind of the mainstay. Do you see patients on one of these or both of these at the same time? Is it usually both? Both.
Yeah. Though something I meant to mention with riluzole is there's still a fair amount of side effects, especially with riluzole, for instance. None of them like huge. It's not like brain hemorrhaging like with the drug I've already forgotten the name of for Alzheimer's. That's how significant it is that I forget it after 10 minutes. Aducanumab. But there are a fair amount of side effects: nausea, dizziness, asthenia, hypertension, peripheral edema, various things that could be bothersome to patients. So the general sentiment is, well, we just don't have much for ALS, so any benefit is good. So if we have any improvement in functional status or any survival benefit, then that's a good thing. So like we would kind of discount those side effects. But I've heard the sentiment from at least 3 patients, and I haven't talked to that many, who I was counseling on a new start of one of these medications, basically saying they would say if they see, because they know, they've looked into it, they know like their prognosis and they know what benefit they may or may not get from these drugs. And so almost across the board, they say, if I have any side effects that are bothersome, I'm going to stop it. And so it's not uncommon for it to be stopped for seemingly not super significant side effects, but it's because, morbidly, if you've only got a few years, you'd rather it not be spent with any sort of side effects that you can avoid, especially because they're going to have a whole host of issues. Though those are all older patients that I was talking to, I don't know, maybe the sentiment will be different from a younger patient who was diagnosed, because there are young people who are diagnosed.
Yeah. I mean, I think it depends on like what the side effect is. And I think it depends on like the real life expectancy that is to be expected to be gained from being on the medication. That's what I think would do it for me.
Right.
But I'm also not in that situation, so I have no idea what I would do.
Right. And it depends
I feel like I would take the meds if I could.
Yeah, I'd like to think so. It's hard for me to put myself in that position. Yeah. But so the new drug, I mentioned that the brand name was Relyvrio, I think is how you pronounce it. The generic is sodium phenylbutyrate-taurursodiol, or taurursodiol. Is that how you said it? Taur, like for Taurus.
Yeah.
Because it is spelled Taur.
But then Cole says, what, Taurus?
I say Taurus.
So we don't know who's wrong.
I grew up with somebody in high school who had a Taurus. And that's how she said it, and that's probably why. Probably why I thought so.
I think she was saying it wrong.
Well, she was from
Aiken.
Actually, she was.
So is she?
The Valley is what we call it.
Okay.
But yes, basically Aiken.
Oh, yeah. So there you go.
Yeah. So she was pretty southern.
She couldn't help it.
Right. So the taurursodiol, or whatever, however you pronounce it, is also called ursodoxycoltarine. I don't know. So how these work, ultimately what this drug does, similar to riluzole, they're not entirely sure exactly how it's helping with ALS, but pharmacokinetically, we can kind of talk about what it's doing in the body. So ultimately, it reduces neuronal cell death. So I guess that makes sense that it might prevent progression. But these are 2 different drugs. It's a combo drug. The one, sodium phenylbutyrate, is a histone deacetylase inhibitor that reduces an adaptive stress response in the endoplasmic reticulum. Taurursodiol appears to increase the threshold of cellular apoptosis by maintaining mitochondrial integrity through reduced membrane permeability. So combining those leads to reduced neuronal cell death. So the authors of Up to Date suggest this Relyvrio for all patients with ALS, similar to how they do with riluzole. The study, like I said, it was a little bit controversial, and it's really only controversial because there wasn't survival benefit in that study, and it was still FDA approved. But there was...
But not at first. That's what's even weirder.
Right.
So it's like, I think one of the only... I'm sure it's happened before, but one of the only times where they've ever gotten like a second look at the application, I guess. And
right.
Then
so it was denied.
Right.
And then they approved it. With, I guess, the promise of this other study, you said it's Phoenix.
Phoenix, yeah.
Right. That is hopefully better. So let's talk about this one a little bit. So I believe this is the same one. Yes. So there was a study with 137 patients for ALS. That's the regular study size.
Yeah.
Who were within 18 months of symptom onset. More than 75% of patients were also taking riluzole or edaravone. So they could be taking either. I can't remember if you mentioned it, but edaravone was historically only IV. But they recently approved a oral suspension. Yeah, that's recent. Anyways, in the study, I'm pretty sure that originally...
You're talking about the Centaur study at this point for the new drug?
Yes.
Okay.
I think that's the one. I'm not big on names.
Okay. I think that's the one you're talking. Go ahead.
I think that's the one, though.
Okay.
137 patients.
Make sure I'm. Yeah.
This is not Phoenix. This
Centaur.
Is not Phoenix. Yes. So
just making sure we're looking at the same trial.
With the original inclusion criteria, they allowed patients to be on riluzole. Some were on riluzole, some weren't. And then they addended it to allow patients to also be on edaravone, because from when the study started, edaravone was not around. And then during the course of the study, it was approved. So they did allow patients to be on edaravone. 28% were taking both together of the 137. And the median revised ALS functional rating scale, so that's ALS-FR score, was 36. The maximum score is 48. So I think this is a good time to kind of talk about what that is. Did you have anything pulled up on that?
Yeah, the progression.
The ALS-FRS score. Yeah, I had something if you didn't.
Go ahead. I have like a very long thing about it, so I'll see what you're saying.
Okay,
I'll add to it.
Basically, it's just a scoring scale of symptoms. And so the higher the score, the better, right? And then the lower the score, the worse. And the reason being, they look at a number of things: speech, salivation, swallowing, handwriting, their gastrostomy status, depending on how they're taking their food intake, how they're cutting food and handling utensils, dressing, hygiene, turning in bed,
handwriting,
walking, climbing stairs, a whole bunch of stuff. Lung capacity questions. It's a number of things.
So it's basically respiratory, gross motor skills, vulvar, so like the speech and salivation, and then fine motor skills.
Exactly.
So those 4. So you can get up to a max of 48 points, or the minimum score is obviously 0 if you can't do any of them.
And so to make that kind of make sense, so for speech, for instance, if your speech is normal, you get 4 points for that. If you have total loss of useful speech, you get 0 points for that. So that's why higher score is better, lower score is worse. So what we're looking for in the studies is for the score to be maintained. So to see, because it might bounce up a little bit, that'd be great. But it's a progressive disease. So hopefully what we're looking for is for it not to progress further than placebo and for that to be statistically significant. And you have to take some of that with a grain of salt too, because these scoring systems are, even though it is generally related to quality of life and functional status, is almost like a composite endpoint, right? Mm-hmm. Because I mean, to me, being able to speak might be a little more important than just additional saliva or something like that, like hypersalivation, but they get the scores are weighed the same.
Well, also too, if like let's say you gain 1 point back in each category or whatever, that may be able to push you numerically to a better situation, but from a clinical standpoint, it's really not that much improvement. Right.
Or it's at least relative to where we're saying that this is clinically significant, or we're saying that this is significant, but it might be barely noticeable from a patient's quality of life standpoint. Anyways, that's just stuff to keep in mind. And part of the reason why they didn't feel like the results were super strong, and part of the reason why I had trouble getting through, was because long story short, they did see a reduction or an improvement in this score in the study, but not survival.
Longevity.
So I'll give you some more specifics. So by the 24-week follow-up, those treated with Relyvrio showed a slower rate of decline in that score than those treated with placebo. So the difference was there was a 1.24 reduction in the Relyvrio group and a 1.66 reduction in the placebo group. So like I said, the median score was 36, and basically there was a 0.42 per month point difference between treatment and placebo.
Yeah.
Doesn't sound too fantastic, does it?
Sure doesn't.
It's like,
especially when you think about that being clinically relevant.
Super slim.
Yeah.
To me. Yet the updated authors say everybody should get this.
I mean, I truly feel like it's one of those things. It's because we just don't have anything else. So it's like, just try something.
Right.
I mean, and I get that. I don't know that it's going to be a cost-effective plan, but I do get the sentiment behind it, I guess.
Right. And so that was a big issue with the aducanumab, was the cost thing, right?
But then that one has such serious adverse effects. That's a huge
adverse effects, and a lot more people who would get it. So the big concern was, should this be a recommended thing so that Medicare has to cover it? Yeah, and it was like this whole big system-wide healthcare concern about the cost. ALS is a relatively small number of people. And so even though if this was recommended across the board, it's not going to be a huge financial burden on like the healthcare system or anything like that.
Yeah.
And yes, the adverse effects are much less. So, well, you wanted to say some things?
Well, I was just going to say that when it got, they took the data from that study from Centaur, and that's what they presented to the FDA. And like Cole said, basically their decision had gotten pushed back so they could get more information. And initially there was two panelists that basically voted no. That after they saw the new information, they changed their vote to yes. Whereas there were still some other patients, or some other panelists rather. So I'm reading a quote now. It says, "Unfortunately, I don't believe the new evidence we've reviewed, while promising, combined with that prior evidence, constitutes substantial evidence of effectiveness," was one of the guys in the panel. And so it's one of those things that he still voted no and didn't change his mind. So definitely kind of a subjective opinion, which I guess is why they have the system as a voting thing like they do.
Yeah.
But basically the Phoenix trial is ongoing now. They're expecting it to finish between 2023, at the end of the 2023, and then the beginning of 2024. And hopefully that will show an increase in lifespan.
Yes.
And if that does, then we'll probably be good to go, and the FDA will continue to advocate for the drug, but and keep it approved. But if it doesn't, I think that's where they expect it to be removed.
Right. And so that's a 48-week long-term efficacy and safety trial. And the word on the street is it's trending towards positive.
Yeah.
But of course they're going to say that until the data is done. So I'm interested to see what it says. But hopefully it's good.
Just positive vibes,
speaking
into existence.
I mean, it's such a sad disease state. You don't want to
you definitely
don't want to wish, you don't want to hope that it's not going to work.
No,
right?
100%. I hope it's the best drug ever.
Yeah, I hope
especially
it's
for
like
ALS.
Amazing.
I'm just saying from their point of view.
Right.
Yeah, I get it.
Right.
They definitely don't want to. Yeah, it's not looking real promising.
Right. The drug company doesn't want to do
Stock
that.
plummets.
Right. So the last thing I had was just a couple things on dosing and side effects. It's a powder that's actually reconstituted by the patient. I think it's in 6 to 8 ounces of water. It says to stir vigorously before administering. Can be given orally or by gastric tube once a day for 3 weeks and then twice daily after that. The side effects are relatively, non-specific, benign: diarrhea, abdominal pain, nausea, upper respiratory tract infection. I think the diarrhea is in about 25% of patients. So even though it isn't brain hemorrhage, still, a significant amount of diarrhea or abdominal pain can be bothersome to a patient. So it's still up to them whether they want to do it. But at least it's not going to be any big scary side effects that it can cause.
Yeah.
Yeah.
All right, man. What do you think? Anything else?
I think we did it.
Did we make it?
I think we made it.
I think we did the bare minimum that we could.
Maybe someday we'll come back and do like a full ALS episode where we talk about all the supportive stuff or whatever. Yeah.
That'd be good. We'll do more research before we jump on that episode.
Yeah.
We'll plan better.
A little more prep.
But we appreciate it nonetheless, and I hope that was somewhat helpful. Also, make sure you guys check out our sponsor, pearls.com. For those of you who are watching the video version, go to pearls.com/coreconsultrx. Type that in the URL. You'll come up with this page, and you can sign up for a free account and get access to a lot of their content, a bunch of free charts that you can print off and save on your computer as PDF files. And if you like the app, obviously you can upgrade to the pro version and get all the content unlocked. Which is also a very affordable and good plan. So check that out. Derek from Pearls has been fantastic as far as sponsoring us, and was one of, like I've said several times, one of our kind of first big sponsor that we had. So big thanks to them, and make sure you check them out. The app is growing every single month and adding more content. So I think it's going to be a really cool feature here, especially as the months go on. So maybe one day give Lexicomp a run. But thank you so much for Pearls. Make sure you check them out. If you want more like lecture style episodes where we're not just talking and giving our opinions on stuff, check out patreon.com/coreconsultrx. And now all the lectures are actually like put in the proper categories, cardiology, neurology, so you don't have to just like scroll endlessly to find lectures. I got a little more organized now. A lot of new people have joined over the last month, so I really appreciate that. That helps us to pay for equipment equipment and all the cool stuff for the podcast that, at least makes us feel professional. But thank you guys so much. I hope you have a good rest of your week, and just email us, text us, DM us, whatever. If you have questions or comments, we'll do our best to get back to you. Y'all have a great night. See ya.